Now my very great pleasure to introduce Dr. Tania Gonzalez Rivera. So just a few short years ago, the foundation was, I guess, blissfully unaware of a company called Cabaletta and blissfully unaware of the potential for CAR T and autoimmune disease. And we were at a conference and Dr. Arun Das from Cabaletta approached us and we started a conversation. And I think as I started off this symposium, the rate of pace and change that is happening in treatment of autoimmune disease is really quite impressive and really quite stellar. And Cabaletta are clearly one of the leaders out in that and have been interacting, I think importantly, with a patient organisation such as the CureJM Foundation to really help migrate their therapy into a potential JM clinical trial. So my very great pleasure to introduce Dr. Rivera. She's an executive leader in the biotechnology industry, currently serves as the VP of Medical Affairs at Cabaletta Bio, which I think, as most of us know, is a company developing novel therapies for autoimmune diseases. She completed her Doctor of Medicine and residency at the University of Puerto Rico School of Medicine and her rheumatology fellowship at the University of Michigan Medical School. Her research and clinical expertise includes autoimmune diseases, particularly in the areas of rheumatology and dermatology. She's published numerous papers and journals on topics such as psoriasis, lupus, and skin cancer, as well as presenting at a range of major scientific conferences. So Dr. Rivera, over to you to talk to us about realizing the CAR T potential in myositis and beyond.
Thank you for that introduction. Let me share my display settings. Give me 1 minute. Can you see my slides?
Perfect.
Okay, perfect. So good afternoon to everyone in the US and good evening to the colleagues in Europe. I know it's quite late, so I appreciate you sticking it out for the last part of the symposium. As Andrew mentioned, I'm Tania. I am part of Cabaletta Bio, and I am very grateful for the opportunity that Andrew, CureJM, and the other organizers have given us to be able to be part of the symposium. I've learned quite a bit today. It's been great to be an honor to be part of this panel presenting. This is our standard disclaimer slide. As a publicly traded company, it's not an eye test. I'm not going to test you to see if you can see all the language here. But my goal today in the next 20 minutes is to shed light as to why it makes sense to use CAR T-cell therapy in the management of autoimmune diseases such as myositis. I would also like to take the opportunity to talk a little bit about CABA-201, which is our product candidate, and our RESET trials, which are ongoing. To set the stage for the rationale of CD19 CAR T, I felt the need to sort of level set as to why it makes sense and understand a little bit about the role of B cells in autoimmune diseases. And I know this is not going to be new information to all of you, but I really felt that it needed to be sort of set the stage. And I think Matthew before showed a timeline of all that we've come to understand about the myositis specific antibodies. And I feel that since I did my fellowship in 2008, there has been an increased understanding in the different subsets of myositis and the different autoantibodies that have clinical correlation and help us characterize our patients better. But despite advances in the management of several autoimmune diseases such as lupus, rheumatoid arthritis, psoriatic arthritis, there's still a huge unmet need for patients with myositis, and especially patients with juvenile onset myositis. This disease, as we've heard from others earlier today, presents a high burden on function and quality of life, and especially a high mortality rate due to the associated comorbid conditions such as ILD, cardiovascular disease, and malignancy. B cells play a central role in many of our autoimmune diseases, and this could be by a variety of mechanisms. It could be due to autoantibody production, antigen presentation, T cell co-stimulation, production of those inflammatory cytokines that cause the manifestations in our patients, and also class 2 antigen presentation. So this is another aspect that has evolved quite a bit in terms of how instrumental B cells can be more than just producing autoantibodies in autoimmune diseases. And targeting B cells may be an effective way to treat diseases that are driven by B and T cells. And I believe Matthew also used the picture on the bottom, but there's really evidence of B cells and humoral immunity in muscle biopsies. On the top of your screen, you will see staining for CD20 positive B cells seen in muscle biopsies in different subsets of DM patients. And on the bottom, you'll see antibody deposition in muscle fiber nuclei of an anti-MI2 patient. And as mentioned previously by one of the panelists, rituximab has been looked at in myositis in a double-blind randomized controlled trial of 200 patients, which included 50 juvenile dermatomyositis patients. And unfortunately, among the 200 randomized patients, 195 of them showed no difference in the time to definition of improvement between those that received rituximab late or early. However, the overall response rate in the refractory group of patients, the ability to taper glucocorticoid therapy, and the retreatment response suggested that rituximab could have an effect, but that certain aspects of the study design really made it challenging to see an effect. And this has been the case also in other autoimmune diseases such as lupus and lupus nephritis, where we know that clinically we see an improvement when we give rituximab to some of those patients, but really when the Explorer and Lunar trials looked at rituximab formally in an RCT, we weren't able to really show a benefit. And beyond the potential study design questions, there are mechanistic reasons for potentially why rituximab didn't work in myositis and other autoimmune diseases. And one key aspect is the difficulty for rituximab to really deplete those tissue-resident B cells, those that are in the lymphoid tissues. In lupus nephritis, they are in the kidney. In myositis patients, they could be in the muscle. So those cells are really not as accessible to rituximab. So perhaps that's one of the reasons why we didn't see an effect with rituximab. Additionally, looking at peripheral B cells and depletion of those B cells in the peripheral blood really doesn't necessarily correlate with or predicts tissue depletion of these B cells. And then additionally, we're only targeting CD20. So those cells that are not CD20 positive will not be depleted. There are newer anti-CD20 therapies such as obinutuzumab that have been showing some promise in some autoimmune diseases, but really the jury is still out. And the question remains, how can we address pathogenic B cells that are causing manifestations in our patients? And that's where the chimeric antigen receptor T cell therapy comes into play. And CAR T therapy has really revolutionized the way that B cell malignancies have been managed in the last 10 years. CAR T cells are engineered T cells that are directed to a specific antigen using a synthetic receptor. So let me orient you on the left side of your screen. You'll see the white and blue cells, and those are the disease-causing target cells. In the case of malignancies, those are the B cells that are tumor or they're part of the lymphoma. On the bottom, you'll see the engineered T cell with a targeting domain and an antigen receptor that has been modified to now only target CD19 positive cells. Since 2017, there have been 4 CD19 CAR T cells that are FDA approved for the treatment of B cell malignancies, and their results in terms of complete remission and long-term remission have been quite impressive. And just to give a snapshot of what does it mean or how do we generate this CAR T cells, And really what we refer to CAR T cells is a living drug. The patient is really the source of the T cells. We extract them through leukapheresis. And after those cells are extracted, they are reprogrammed with viral vectors, and they deliver a gene that codes for this chimeric antigen receptor. The cells are proliferated and expanded in a bioreactor, and then they're infused back to the patient, and that's number 6 at the end. If you pay attention to step 5, you see that it says chemotherapy, and that's a step that is frequently referred to as preconditioning or lymphodepletion. And it's a regimen that in oncology has been demonstrated to help the CAR T cells function, and it usually consists of fludarabine and cyclophosphamide. So the efficacy that we've seen with CD19 CAR T therapy in oncology has been pretty impressive, but there are adverse events that have been reported in association with these therapies. Two of the most common ones are CRS or ICANS, which stands for cytokine release syndrome or immune effector cell-associated neurotoxicity syndrome, respectively. These two entities are really secondary to basically a cytokine storm. When the CAR T cell interacts with the target cell, there's secretion of interferon gamma and TNF alpha, and subsequently there is a resultant storm of predominantly IL-1 and IL-6, and that really manifests as CRS or ICANS. And both can range from mild, but they can also be life-threatening. And really, it's a very tricky time in management for these patients post-CAR T in oncology, because we are really making these patients B-cell aplastic. There's a risk for infection and hypogammaglobulinemia. There is a risk of secondary malignancies, including T-cell lymphomas, and this has been recently in the news. Back in December of 2023, the FDA has been made aware of about 22 cases of T-cell lymphomas, and that led in April of 2024 for a box warning for the 4 therapies that are approved in oncology to as a box warning for the potential of T-cell lymphomas. Since then, both Stanford and Penn have evaluated their cohorts, and the incidence of secondary malignancies has been 2.3 at Penn and 3.4 at Stanford, with only a single case of a T-cell lymphoma in these patients. So really the jury is still out. Is this related to the CAR? Is this related to all the prior chemotherapies that these patients had received prior to getting CAR T therapy? Interestingly, the risk factors for CRS and ICANS, which are a high B-cell target serve burden and the large dose or the high dose of CAR T that these patients receive, those 2 factors are not as important in autoimmune diseases, because the target burden or the B cells, the number of B cells is not as high as in a B-cell malignancy, and then the doses that we're administering are not as large as used in oncology. So as a summary, as part of the rationale of using CD19 CAR T in myositis, 1, B cells play a role in the pathogenesis. Using anti-CD20 mediated depletion of B cells has been incomplete, and the responses have not been durable. We know that CD19 CAR T cells are able to traffic through the tissue, so potentially we could be addressing those tissue resident cells. And then CD19 CAR T has already demonstrated clinical efficacy and safety in hematologic malignancies in thousands of patients. And since 2021, there have been reports in the literature from the German group led by Professor Schett about patients being treated with a CD19 CAR T and with promising results. And in February of this year, in the New England Journal, there was an update of these 15 patients and how they're faring after receiving CD19 CAR T. So the group has evaluated 15 patients with refractory systemic autoimmune disease, all adults. There were 3 myositis patients, 8 lupus patients, and 4 systemic sclerosis patients. They all had inadequate response to at least 2 lines of therapy, had disease for more than a year, and they were mostly female. Half of the patients had received some level of B-cell depletion therapy. And what we see is here on this slide is how did the CAR T cells perform? So once they were infused, you see on the left side of your screen, you see a peak that occurs around 10 to 12 days post-infusion in these patients. You see a peak of those CAR T cells, and then subsequently by day 30, you basically undetectable. On the right side of the screen, concurrently, you see the transient white blood cell decrease or leukopenia that occurs, which is mostly secondary to the preconditioning with fludarabine and cyclophosphamide. But at the same time, you see that despite the white blood cell count recovering 30 days in some patients post CAR T cell therapy, you still see predominance of the CD19 B cells actually still being absent. The reconstitution that occurs within 7 months of receiving CAR T therapy is interesting as well. So the subset of B cells that are now present in these patients are naive B cells, and you can see it on the top right side of the screen, where the subsets of cells are predominantly naive and with decreases in the memory B cells and plasmablasts. So in terms of efficacy, what was seen in these patients? And it was really impressive when this data came out, because not only did the patients present with clinical responses for myositis, you see that by 3 months, there was a response in these patients, both on CK level and the T-score, but also for lupus as well, and for systemic sclerosis. But importantly, these patients achieve this with no other background therapies. And this is really what has been striking about these patients, is that not only are we seeing a clinical response at different time points, but really that they have no background therapy and are able to maintain their disease quiescent. Since the paper was published in February, there has been a report that one of the myositis patients had a recurrence of their muscle disease about a year and a half after CAR T, with no recurrence really of their lung disease. It was a patient who was, I believe, anti-Jo1, and they're still evaluating. So I'm hopeful that at EULAR or any of the future rheumatology congress like ACR, we'll hear more about this patient. In terms of safety and tolerability, it seems that the CD19 CAR T cells are behaving a little bit different than what has been seen in oncology. The rate of CRS and ICANS has been, in terms of severity, has been mild. CRS has mostly consisted of fever, and there's only 1 case of ICANS in a patient with myositis that had mild dizziness, but this resolved rather quickly with a short course of glucocorticoids. Patients, there were patients who developed hypogammaglobulinemia, and 2 of those 5 patients actually had pre-existing hypogamma from previous Rituxan therapy, and vaccine titers to standard vaccinations all remain stable. In terms of infections, most of the infections were mild and mostly manifested as upper respiratory tract infections. Only one infection led to hospitalization in a lupus patient due to pneumonia, and it resolved with antibiotics. So now shifting gears to talk a little bit about what is CABA-201. And it is important to mention that the construct and the CD19 CAR T that the Schett group used is not necessarily, it's not the same construct as ours, but there's a fair amount of similarities both in vitro and in vivo. And the similarities exist in terms of the anti-CD19 binder, which is the top part of the molecule that you see on your screen. And the 4-1BB co-stimulatory domain is also similar to the construct used by the Schett group. And how are we looking at CABA-201 in myositis? So we currently have an active phase 1/2 study looking at CABA-201 in adult patients with myositis. We have 3 cohorts, one for dermatomyositis patients, one for antisynthetase syndrome, and one for IMNM. All the patients are going to receive a single dose of our CAR-T or our CABA-201, and the primary endpoint is going to be at 28 days, and it's looking at the incidence and severity of AEs measured 28 days after CABA-201 infusion. And of note, one of the ones that we're really looking at is, are these patients developing infections? Are these patients developing CRS or ICANS in those first 28 days? Because that's the highest risk to develop CRS and ICANS. We're also looking at several secondary endpoints, such as efficacy. We're looking at biomarkers such as CK. In myositis patients, we're looking at what are those B cells doing after receiving CAR-T. So all of those are other secondary endpoints. And this is just a snapshot to show that we're looking at CABA-201 in a variety of autoimmune diseases in addition to myositis. We're looking at it in lupus, in systemic sclerosis, in myasthenia gravis, and also we're going to have a sub-study in pemphigus vulgaris patients. And currently we have active sites in the US, and new sites are being added regularly. If you want to look at our current list of locations, you can always look at our clinicaltrials.gov entry, and this is the study number. And if any of I know that most of you right now are treating pediatric patients, but if any of your patients would be interested in understanding more, we also have a patient-focused website that you can see on the bottom, www.reset-myositis-trial.com. And to conclude, I also wanted to give an update on what is going on with CABA-201 and our RESET trial. Since the beginning of the year, the FDA has granted CABA-201 with Fast Track designation for patients with dermatomyositis, orphan drug designation for the treatment of idiopathic inflammatory myopathies, and importantly, a rare pediatric disease designation for the treatment of juvenile dermatomyositis. And we're very committed at really understanding and providing potential opportunity for patients with juvenile dermatomyositis to be included in our trial. Excitingly, last week, we disclosed that we have treated 2 patients in the RESET trials, one for the myositis trial and one for the lupus trial, and both have done well with no CRS or ICANS of any grade in the 28-day drug-limiting toxicity window. Lastly, if any of you are going to EULAR, we have a symposium scheduled for June 14th to talk a little bit more about CAR-T and also disclose additional clinical information on these 2 patients. We will have Carl June, who is the pioneer of CAR-T cell therapy, give us a snapshot of his experience in oncology and why it makes sense to move into autoimmune disease. Professor Schett will be presenting his own data on the patients that I mentioned early on. And our CMO, Dr. David Chang, will be in charge of giving us more information about those patients that already are in our RESET study. And with that, I want to say thank you once again. My email is on the bottom. If you have any questions about the trial or you want to have more information, please feel free to reach out.
Thank you so much, Tania, and thank you for agreeing to go last in the symposium. It's never a great slot to take, but I think the excitement that we all have for CAR-T and JDM is palpable, and we're really looking forward to hearing more from your team as you enroll more patients in the study. And I know we are actively involved as a patient organisation in your future planning, and we're excited about that and very keen to stay involved. It's open for questions, and there's one from our very good colleague in Italy, Rebecca Nicolai. Are you planning on opening a pediatric site in Europe?
Yeah, so at this point, we're in conversations with the regulatory agencies, both in the US and ex-US, to understand what would be the path to open sites for pediatric patients in our research study. So we're in active conversations for that.
I guess from a foundation perspective, we're always interested in, as you're opening, pediatric and adult studies. In your adult studies, are you actively looking for JM patients, not DM patients, if you like? So patients that may have been diagnosed with JM and then aged out to the over 18 bracket.
So actually, for our current reset myositis trial, patients have to be older than 18, but they actually could have had a diagnosis of juvenile myositis. So we are capturing those patients in our current trial.
Okay, and I know that you, David and Arun, are using us somewhat as a resource for helping you find patients. But I think just to reiterate that on behalf of the foundation and the board and all our patients and families, please maintain the dialogue. And we have an amazing resource, and I know Lauren and Shannon would help with that significantly.
No, I appreciate it. And once we have a more defined plan and timelines, we would be very grateful if we could partner with you to really find the right patients and be able to provide this option. So definitely we will reach out when the time comes to help with enrollment and identifying patients and potentially investigators as well. I
think we know quite a few investigators as well. I think there's several of them are still on the call. If there are no more questions for Tania, it just remains for me to wrap up the day.